Hi, I'm Dr. Simon Fryer, consultant in clinical neurophysiology. Welcome to my channel. Hopefully you will have watched the first part of this video where I provided an overview of normative data. If you haven't seen this yet, please do so now by clicking on the icard above. In this video, I will provide an overview as to how we interpret the information we've pieced together from the studies and come up with a diagnosis. For any nerve we measure, the size of the response, called the amplitude, and this generally reflects the size of the underlying axonal fibres, especially for the sensory nerves, and the speed of the response, which reflects the degree that the nerve is myelinated. So when the amplitude drops, we generally attribute it to axonal loss. And where the speed of conduction drops, we generally attribute it to demyelination. Of course, it's more complicated in the motor responses where we're measuring the muscle fibre as well. For clarity, if we were to take a sensory nerve and we stimulate it at one point and we record at a distant point, then we are testing how the current is transmitted across the fibres, and so any loss in axons will result in a loss of amplitude. However, it is more complicated in motor nerve studies because we are stimulating the nerve fibres, but we're recording over muscle fibres. Hence, a reduction in the motor responses could be due to a loss of motor nerve axonal fibres or potentially due to a loss of muscle fibres. This is where EMG comes in because we can distinguish between neurogenic and myopathic changes within the muscles. You can see further tutorials regarding neuropathic EMG and myopathic EMG changes by following the iCards above. For now, I just want to highlight that because motor nerves are larger and more myelinated than the sensory nerves, they are better at showing conduction slowing. And we'll talk more about this later on in this video. So let's start with the demyelinating mononeuropathies at common compression sites, which are, of course, by far the commonest of conditions that we encounter. These include carpal tunnel syndrome, cubital tunnel syndrome, common peroneal nerve lesions at the fibular neck. Here, single nerves are being compressed and damaged. We test the nerves to look for focal motor conduction slowing at the entrapment site. You can see videos on all three of these conditions by following the iCards above. Sometimes they can coexist, such as having both carpal and cubital tunnel lesions simultaneously. This is not rare, and I see this in around 5% of my carpal tunnel patients, so I keep an eye out for this, and you can see me perform a typical carpal tunnel nerve conduction test in under 2 minutes by following the iCard above. If we see conduction slowing across all common compression sites, especially in a young patient, then we need to consider a condition called HNPP, or hereditary liability to pressure palsies, as a potential underlying cause. Here, a genetic mutation in a myelin component makes the nerve susceptible to becoming crushed. Keeping to the genetic neuropathy theme, when we encounter conduction slowing, which is uniform, symmetrical, and outside of simple entrapment sites, we must consider the hereditary motor and sensory neuropathies, and you can see a video explaining the different types of Charcot-Marie tooth disease by either following the iCard above or seeing in the description box below. Inflammatory demyelinating neuropathies, by contrast, are much more patchy, often more asymmetrical, and tend to demonstrate phenomena called conduction block and temporal dispersion. This is where non-uniform dysfunction in the nerves leads to a reduction or spread of the motor responses. You can see a more detailed explanation of this and myelin function and nerve signalling by clicking on the iCard above and the description box below, as well as some videos explaining the inflammatory demyelinating neuropathies. Any demyelinating neuropathy which is sufficiently severe will eventually lead to underlying axonal fibre loss, recognisable as a drop in the amplitude. So let's talk about the axonal neuropathies, and these can really be subdivided into a few categories: length dependent, generalised, mononeuropathies, and mononeuritis multiplex patterns. The commonest are the length dependent neuropathies. These occur in the more distal and smaller caliber nerves, hence the sensory fibres tend to be more affected than the larger motor fibres, and so the feet are also affected first and tend to clinically affect the hands by the time the impairment reaches the level of the knees. Of course, we can detect subclinical involvement earlier with nerve conduction studies in the hands. So generalised neuropathies will lead to generalised suppression of the amplitude, which will again affect the sensory fibres more than the motor fibres in general. Perhaps the most interesting variation are the sensory neuronopathies or ganglionopathies, where there is a complete suppression of all sensory responses. And I would advocate that anyone who encounters this should perform a blink reflex study in these situations to look for trigeminal dysfunction too. Single nerve lesions can also be detected, and these are called mononeuropathies. These can be idiopathic or inflammatory in nature. Where multiple single nerves are affected, this is called mononeuritis multiplex and tends to be associated with inflammatory or vasculitic processes. Pure motor neuropathies are very rare. These primarily affect the motor responses and only rarely affect the sensory responses as well. Differentials in these scenarios can include inflammatory neuropathy such as MMN-CB or MMN without CB, distal HMN, and the motor neuronopathies such as motor neurone disease. Myopathies can also lead to reduced motor responses, but often, as they are more proximal processes, the distal motor amplitudes tend to be spared unless it is a distal myopathy. An interesting exception is critical care myopathy, where the motor responses reduce and become broad as well. However, what we do commonly encounter are the radiculopathies. Here, myotomal motor axonal loss is demonstrable without sensory fibre loss. Take a look at the medical student tutorials that I've produced via the link above, where I explain how we differentiate between pre- and post-ganglionic lesions, which is very, very important as a concept in clinical neurophysiology and localising lesions. So that's the whistle-stop tour, and in the coming series of videos I'll work through some specific examples. Thanks again for watching, and I hope you enjoyed it. Please do support this channel by liking, sharing and subscribing. Thank you so much, and I hope to see you in the next video.